Join us as we explore evidence-based practice, manual medicine, and sports science through the lens of movement, strength, performance, and overall health.
Welcome to the podcast, Dr. Andre White, absolute sporting legend from what I've heard.
Used to be.
And obviously co-host up there in the corner, Dr. Stephen. I like to call him the Tony Stark of chiropractic. So I start every podcast saying that, and I'm hoping that it sticks. I didn't actually come up with it. Didn't your boss come up with it, Stephen?
He's not my boss, but my mentor, yeah.
Your mentor came up with it. So I've been saying it in every podcast. I'm hoping it sticks. We'll see how we go. But yeah, anyway, thanks for joining our podcast. I'm excited to have a really good discussion. And I'm just going to read out a little bit of an intro just so that our audience gets a little bit of a rundown of who you are. And then I've got some interesting, maybe some spicy questions to go through to start us off, just for a bit of an icebreaker. Prior to graduating from Life University as a doctor of chiropractic, Dr. Andre studied exercise physiology at KSU, where he was a 5-time Division I All-American track athlete. Winning numerous athletic and academic awards and breaking many records, Dr. Andre competed at some of the most elite track meets in the country. Very impressive. Upon graduating from KSU, he continued with track and field at a professional level, finishing in the top 50 world rankings 8 times for multiple events and competing in the triple jump at the 2016 Olympic trials. It was through this athletic career that he gained interest in becoming a chiropractor, seeing and appreciating the need to maximize his athletic potential by taking better care of his body. Upon retiring, he felt driven to give athletes the same opportunities to maximize their own full athletic potential. Dr. Andre also holds a Master's of Science focusing on sports injury and rehabilitation and believes in patient-centered, evidence-based care that is not only objectively driven but performance-focused. When he's not treating patients, he's enjoying time with his wife, his 3 kids, and their 3 dogs. Wow, 3 dogs. Come on. Welcome to the podcast, Dr. Andre White, or Dr. Dre. Come on. Okay, so I've got some. This is fast-paced questions, and it's legit or bullshit. So what I want from you is a legit or just BS. Right, so you just throw it out there. It's a legit or it's a BS, first time on the podcast, you can pass if you really want to. If it's too controversial, feel free to pass. But we'll see how we go. Okay, are you ready?
Yep.
Vertebral subluxation.
Bullshit.
Exercise and rehab.
Legitimate.
Using x-rays for postural issues or subluxation.
Bullshit.
Massage guns.
Both.
Innate intelligence.
The bullshit.
The chiropractic bone out of place model.
Bullshit.
Using x-rays for red flags.
To rule out red flags, legitimate. Fearmonger, bullshit.
Being able to adjust one single bone at a time.
Bullshit.
Ongoing chiropractic wellness plans.
Depends.
The nervoscope.
Bullshit.
The biopsychosocial model.
Legitimate.
Upper cervical toggle technique.
Bullshit.
That was good. I'm impressed. Honestly, I think I would answer exactly the same.
It's hard because me and Steven have gone through these talks for 3 years now, maybe. There's so much context in there as well with the biopsychosocial model, right? So by agreeing with the patient saying their back is out, well, once I know what that definition from their point of perspective means, then yeah, I can agree with it, because if that just means that they're feeling something that's just not right, maybe proprioceptively they're a little bit off, maybe they have a little bit of a soreness, ache, pain, then yeah, let's go with that. Just because my definition doesn't fit theirs, as long as I know what they're saying, that's what matters to me. Now, when they start saying, yo, my other chiro told me a rib is out, and I tell them explicitly multiple times that ribs just don't go out, and they still say it, then as long as I know we're on the same page, I'm going to continue to tell them. But after the 4th time, I'm not going to waste 45 seconds that I could be spending on another patient who needs my help more than trying to talk to a wall.
I mean, that's the beauty of these questions, is like they're almost, they almost all require context, but you don't have that. Yeah. That's the beauty of it. So there are a few easy ones. I gave you a few easy ones. Okay, here's the last little game before we proceed. I'm going to give you 3 names. Now, you should know all 3 of these people, right? And you have to choose to work for one. This is hypothetically, obviously. Work for one. You have to then hire one, and then you have to fire one. Okay? Now, obviously, this is hypothetical. It's all fun. So, now the 3 names is Dr. Clarence Gonstead, Dr. Mark King, and Dr. Michael Woodbury.
All right. Let's see. I would work for Dr. King. Just to provide context, I think that would be a good way for me to expand my methodology and how I think about things. The couple of times I've heard him talk, I feel like we're on a very similar wavelength, but the way he communicates is a little bit more clear cut. And I think me being quote unquote a newer doc, that could be definitely much more useful than even adjusting sometimes, being able to communicate what my purpose and intent is along with the patient so they actually are compliant and have that faith built. I would fire Gonstead because he has rheumatoid arthritis, and I don't feel like that's good for my malpractice and liability insurance.
I like it.
What was the other one? I would hire Woodbury just because we can work out and roll and take care of each other.
Nice. Wait, so do you also do BJJ?
No, but I want to. But
Okay.
you know, having 3 kids and 3 dogs, it's a little bit harder.
I know it's something I actually really want to get into as well, but it's just like trying to find time. I keep saying to myself, when my son's old enough, like I have a 4-year-old and I want to get him into some type of martial arts. I just think it's good for, honestly, I like beyond just like the physiological benefits of it. I just think it's good for self-esteem. You know, it's good. It's a good lesson on having to break through certain barriers to get good at like learning a skill, right? Just teaching him consistency, hard work, mindset. But I'm trying to like pick a martial art that my wife will allow me to pick, because like she's not going to let me do like she's probably not going to let me put him into like striking some, like, cause you know, like she doesn't like violence. She's like, well, why learn violence if I never want him to do violent stuff? And I'm like, well, you know, I try to explain it to her. But the cool thing about Brazilian Jiu-Jitsu is like it's a really defensive style mythology around the sport, so I can kind of sell it to her. And we were watching a movie the other day, and one of the guys rear-ended choked and like brought one of the like bad guys to the ground, and I was like, see babe, it's like, you know, it's great. And she was like, oh yeah, maybe. I was like,
so if you want to hear a fun story about that, so my first I guess mentor that kind of changed my mindset around wellness-based care and sports chiropractic in a non-philosophical sense was actually my first employer. So I shadowed him for about a year and a half, helping him see patients, doing some of the rehab, just kind of finding out as much as I possibly can, almost like what you would do at a residency. Like you're just diving feet first. He's a team doc for 2 twin brothers, one being Rafael Assunção, which is, I think, is the number 5 bantamweight in the UFC right now. So I was kind of by proxy one of their team docs, and you get to see a lot of injuries, which doesn't really mean anything if you don't know what the words mean, right? So I would go and roll. That way I can know, oh, if you get put in this position, where's the stress strain curve, right? Which tissue is being stressed? I know it looks like the knee, but it's really the hip, stuff like that. Yeah. Well, we had a patient that had like very high functioning autism, but doesn't really like sports. His dad or mom wanted him to get into sports for the discipline, kind of calming down the brain a little bit. He doesn't like physical touch though. He's a tactile person. But for some reason, once he got used to the gi, he loved jiu-jitsu. I don't know if it's because it gets him learning a little bit more about the way the body moves that's outside of the realm that we can see, or if it's just the fact of it's a game. Like he always has to be 5, 6, 7 steps ahead. So that's also another thing you can throw past your wife is the amount of learning about your body and the ways you can push it and use it. It's great. I love my linemen doing it. I love my hurdlers doing it. The only people I don't like doing Brazilian Jiu-Jitsu are gymnastics. They rely too much on flexibility, and they don't do any of the strength and conditioning side of it if they go from gymnastics to BJJ and not doing both concurrently. And it's just asking to flare up probably an underlying spondy. But if she needs some more convincing, I have a couple of years worth of taking care of BJJ athletes, so I can help out with that.
No, I like it, eh? And it's cool to hear that side of it, right? Like, man, there's physiological benefits, and there's even prerequisites, right, of being able to roll with someone. But there's also like cognitive benefits, right? Having to think, having to make decisions in a split moment. And I think teaching young kids that is probably quite beneficial. My wife is an early childhood teacher, and we've done a little bit of research together, looking at some of the psychological aspects of a child's development before 5, and it is super important to be including these types of developmental aspects at that young age. It's so easy just to be like, oh, once they get past 5, they'll go to school and they'll learn everything they need to learn. Especially like kinesio awareness and what you're saying about, once you start rolling with someone, knowing where to put your body, having to make split decisions, like split-second decisions about where to place your body, how to, and thinking 2, 3, 4, 5, 6 steps ahead, like some of the really great people do. I mean, you watch a really good Brazilian jiu-jitsu person roll, and it's like it's like chess, man. They're just it's so impressive. I love watching any athlete at the top end. Like, I love to watch. When I read that you did track and field, and that your background is in sports, I was excited to speak to you, because I'm not even sure if this is on the question list, but something I wanted just to ask you, because this is something I'm huge on, is how do you think your experience as an athlete has impacted positively or even negatively the way you treat your patients, or the way you think as a chiropractor?
That's a great one. I'll go negatively first, because this is probably the biggest thing that feeds into my imposter syndrome, being a quote unquote new doc, or looking like I'm 12 with very bad facial hair. Part of it is because I was so used to pushing myself to extreme limits. I don't have that much empathy when patients come in saying, under the age of like 80, when they come and say, hey, I can't, bend over and touch my toes because my back hurts. And it's like, well, you should still be able to go walk, run, lift. Like, there's certain levels. Or when I see people that relatively and subjectively speaking have a 3 out of 10, 4 out of 10 pain somewhere, it doesn't matter, and it has such a great impact on their life or mental health, that kind of annoys me to my soul. Because I mean, I've seen people with rods in their legs running. I have, friends that don't have legs and run the Olympics. So it's like, I see people push the realms of possibilities so far. It's hard for me to be empathetic. Now, I will be sincere, and I'll tell patients straight up, I don't really care about your pain. I care about you moving better and playing with your kids. Because I'll let them know, your pain just tells me, don't press here too hard. Don't push you this way too far. But I still need you to do these exercises whether you hurt or not. I still need you to do this corrective movement so we can tell the brain it's okay to move that way, whether you hurt or not. So that's the negative side of it. The positive side is the subjectivity of pain in general, or what the body's capable of, greatly depends on your experiences in life, right? So just like you were saying, the early childhood development, if my kid doesn't fall and hurt himself once or twice a day, he's going to have a very low, quote unquote, pain tolerance. He's not going to know what his body's capable of, or what actually, is harmful to him or not. Same thing with patients. So if I see athletes and they say, hey, I can't explain it, something just feels off. I was like, all right, what were you doing? What does it feel like? Most likely, I can probably use my life experiences to try to understand what they're trying to convey. Because sharp pain to me and sharp pain to you might be two different feelings and sensation or stimuli. So the fact of I have that internal definition and kind of thought process definitely helps. The flip side is because I was able to, achieve things most people haven't. I greatly understand that at that level, you can fake a lot of dysfunction, musculoskeletal speaking, and what may be normal or negative on orthopedic tests doesn't mean that that pathology isn't there. So we learn in school, whether you're PT, MD, DO, chiro, if this test is positive, they most likely have this because it's stretching this tissue. And then I'm sitting back thinking, oh, well, I've torn this tissue off and I was still able to run when they told me I wouldn't be able to run. So none of these orthos doesn't matter. I still had an 18 out of whatever on an FMS test 5 days after having my hernia and adductor repaired. So it's like, you can fake it till you make it with a lot of things. So if I can understand that, I can help my patients who are at the high level, who can cheat test a lot more to try to figure out what's going on with them, to try to help them achieve whatever goal they want to achieve.
The value of experience, right? Like for you as a clinician, when you're seeing a patient. It just gives you that extra breadth of knowledge, allows you to make decisions in a way that other people would not. I often talk about, I'm a huge believer in understanding biomechanics if you're going to be treating anyone. If you're any type of, like you said, MD, DC, PT, whatever, AT, whatever you are, if you're in that sphere, in that musculoskeletal area, having that knowledge of biomechanics is so important. But it's like sometimes people that may not have that experience, they kind of lack the ability to make certain decisions because they're making their decisions based on what they were taught at school, what they read in a book, possibly, and their experience with patients and life, right? So that's valid. But without having the athletic, the sports, the lifting, the biomechanical background yourself, it's almost like another well of knowledge you can dip into. And it's exactly what I got from you when you're saying, hey, there's certain things that I know and I felt that I can now relate to my patients and I know how to help them because I've been there, as in the next doc wouldn't know that, would have no idea because they haven't been there. I see this a lot in my world. I am very, I'm the first to admit that I keep my scope very small in terms of what I want to be an expert, and it's all things strength. It's my life. It's what I've done. It's what I'm good at. The thing when it comes to acquiring strength is that to help someone to get to that point, going through it is extremely important. Only having experience, I'm not saying only having experience is enough, because I think obviously you have to understand things beyond just, I put this on my back and I lifted it and I figured it out, right? But having that extra kind of knowledge bank to pull from, so important. So I love, like, when you started talking about experience, I'm just like, man, that resonates with me. Also, what you touched on about pain, like me and Stephen talk about pain, the spectrum of pain to function, it's so interesting how pain can be just so complex, right? Again, what you're saying about with orthopedic tests, it's like press here, touch here, write this down, 1 out of 5, 1 out of 12, 1 out of 18, whatever. You're like giving all these markers and you're writing all this stuff down. And when you're in school, you've got a mentor over your shoulder and you're just freaking the hell out. And you're like trying to write your notes, and like you're spending like 2 hours on your first patient when it's meant to be 20 minutes, and you're just trying to get it done, right? And then you get into the real world and it's like nothing is like kind of coming together, like you said. Like even what they taught us, it's just 1 + 1 really doesn't equal 2 when it comes to musculoskeletal pain. Sometimes, obviously, again, it always comes down to, the other day I put a post on Instagram and I said, all the great clinicians will often say it depends. And it was from Stuart McGill, because every time you ask Stuart McGill a curly question, he will start the answer with, well, it depends. And then he'll go on and lay it out. And Greg Lehman will often say, never trust somebody with a black and white, one-sided strong opinion. Be wary of strong opinions. So it's having that ability to understand context, which we just spoke about as well.
Are you familiar with Andy Galpin?
Yeah.
So he has a thing that kind of changed my thought process around that, where think about the types of people that go to a chiro or a PT, right? Usually it's off the recommendation of somebody else. So many times that's going to be your bigger portion of the pie of demographic, right? Oh, you help this person with this issue, and then I have this issue now, and now I'm seeing you because you helped them, right? That's the normal. Those are the easy. Give me, like, that's a free check. You're gonna help this person in whatever 3 visits, and they're out the door, and they send 17 more people to you. The people where chiros and PTs start blowing smoke up their own ass are the ones that no one knows what's going on. So they've been to 3 PTs, they've been to 3 chiros, and you're the only one that figured it out. It's not because you learn this magical different technique or you follow NDT versus neurodynamics, right? I mean, you're still working with the human body. I think personally, the difference really comes from what Andy Galpin talks about a lot is, if you look at research, it will say this particular set of home exercises with this manipulation technique or manual therapy technique helped 70% of people. That's fine. Most people should be going through that. I personally don't give a shit about that 70%. That 70% will see me, but they're going to get better anyway. I care about the 30%, the ones that didn't respond or had no change or got worse. Those are the people that are going to make or break my practice, are going to make and break my persona as a clinician, right? It's going to build the faith amongst the community, because if I can help those people that the research didn't help, that no one's been able to fix, that's where I need to focus on.
Yeah.
But yet that's not what we study in research. We just push the status quo, that 70% over and over and over again. But all it does is it pigeonholes people. People are millions and millions of possibilities of genetic potential, right? So all that variability, no one's ever going to be textbook. I can't tell how many times I've had a patient come to me. I'm like, something just doesn't feel right. And I send them off and they have a tear, or they have cancer, or they have something odd that doesn't fit the textbook whatsoever. And you're like, get that treated and all their pain goes away, or all their dysfunction goes away. And you're like, okay, well, I'm gonna throw that chapter of the book in the trash and light it on fire, because that was a waste of 11 weeks of my life that I learned about this. But it's those people that think differently, that if people just listen, they can get so much more out of it, which is why I'm glad people are actually having podcasts now, instead of just, listening to Joe Rogan talk about why deadlifts are bad, or all these other people. Because you can be strong. You can do, you can have the biggest biceps in the room and a clipboard and be a good coach. Doesn't mean that when shit hits the fan, you can't still be a good coach,
Yeah. And the cool thing about what you're talking about, that 30%, you're even more likely to see that when you're dealing with athletes that are pushing it, absolutely pushing it to that 9 or 10 out of 10 kind of area. And I know with Dr. Andrew Locke, who's a well-known physio in Australia, he literally talks to me about exactly the same thing you just said. There's so many chiros will see someone and, bang, 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 flying 7, and they know they're probably going to get better within 3 to 6 or 6 to 12 weeks, depending on the tissue injury or whatever it is, right? Sometimes they may just need some pain modulation, a slap on the back, and they're on their way and they feel better. But he's like, what about that 30%? What about that piece of the pie where no one else can help? And so often with Andrew Locke, he tells me stories because he's dealing with dudes that are squatting 400 kgs, like 450 kgs, deadlifting 400 kgs, and they're coming in, and it's like as soon as they walk through the door, they're waddling because their quads are so big. There's nothing textbook about them. And it's like and they present with these issues that are very rarely textbook. And he has some really interesting case studies about ways that he's had to approach helping these people move forward, because it's not really an option to say stop training. It's not an option to say put the barbell down. It's not an option to say you can't compete in 6 weeks when you've spent the last 12 weeks peaking for it. And so I love that mentality of being able to help the people that are in that kind of percentile. Do you find that you see a lot more of that because you're dealing with athletes?
Yes, but slightly for a different reason, because going back to like the more wellness-based stuff, I have a unique view of conservative care because I've spent so much of my life injured and with a true medical team, having multiple PTs, multiple surgeons, so on and so forth. I see value in having multiple brains tackle a situation.
Yeah.
So if I have an athlete coming in and I know they have a torn meniscus, well, that's fine, right? Making sure that biomechanically that force on that tissue is being dampened a little bit so that we can increase the body's ability to protect the knee itself. Cool. That's my job. Now, rehabbing the knee, that's going to be your PT or your AT's job. Whatever pain modulation, biofreeze, icy hot, China gel, NSAIDs, cortisone, that's your MD and your personal preference, right? So if we can all work together, then people usually get the most, especially in the US, out of the insurance. Because one thing that kind of made me start thinking this way is I got a lot of patients post-surgical for, like, let's say rotator cuff, where they're seeing a PT, but then they start communicating. We've all gone through this, going through PT. You hurt or you're so tight, it's hard to do the corrective exercises correctly, right? So now you're sacrificing your biomechanic potential for comfort. Well, what if you can go see a DC or an athletic trainer, massage therapist, whatever, and it allows you to get a little bit more motion, a little bit less pain, so you can do your PT better. In the US, that's beneficial because some insurance company only give you about 20 visits a year for injuries for a PT, and they'll give you 20 for a chiro. So now you can use 40 total tackling the same issue and actually clearing it instead of it becoming a chronic issue down the line. And they're doing different things. You're learning so much more from two different points of view. I think we need more of that, but it's kind of hard when there's so many middlemen involved and you have to play nicely with others. And I don't play nicely with others. Not because of, I think I know more, but I know I ask better questions that people don't ask. So if I ask better questions, I'm getting better answers. I can't go up and tell your coach, hey, take them out of this exercise because this is what's causing their pain. This is what's the insulting factor on the tissue. And they're like, oh, well, I know better. I've been doing this for 20 years. Yeah, that's fine. But also you don't know what this muscle is called. So let's stay in our lanes a little bit and let's talk about how can we modify this for the patient's benefit, not for your ego.
Yeah.
And that's something that is lost amongst all manual therapy.
I interrupt this podcast to thank Raisies for sponsoring the Strengthandchiro podcast. Raisies is a family-owned New Zealand business that only produces high-quality, all-natural and clean products. If you're anything like me and you need a protein that tastes good, mixes well, and contains no additives or nasty preservatives, this is for you. This protein is New Zealand-made, ultra-filtered, gluten and GMO-free with no artificial flavors or colorings. If you are an athlete or you love to train hard, it is essential that you get an adequate amount of protein. We would like to thank Raisies once again for sponsoring the podcast. You can get 10% off at raisies.co.nz. So how do you find, so that kind of philosophy or thought process that you're just describing, how do you find that challenges you when you're working, because you work with Stephen on the weekends, is that right?
Not with me, but at the same company.
Okay, exactly right. Okay. So how does that philosophy that you were just explaining, how is that challenged when you're working in a fast-paced place like you are on the weekends with the average person?
I do a lot of work in the front end. So when I first see a patient, I'm giving a lot of patient education. Not because, like, for instance, I'm giving them tactile cues, I'm giving them visual cues, I'm also giving them educational cues. So like, here's what when I say this is what I'm looking for. I try to define what I'm saying to them so they have an understanding. I also tell them, hey, you may have heard this before, and that's perfectly fine, right? I'm not going to try to insult your intelligence, but I need to know that you heard this before. So I'm going to say it again. If you heard it before, just ignore it. That's fine. But by doing that, I'm setting the foundation so that when they start putting the pieces together, it's almost like a murder mystery, right? You have all the pins on the corkboard and all that stupid red line going everywhere that means Steven can't see. It starts connecting the dots over time, but it's not me connecting the dots. It's them doing themselves. So the biopsychosocial now comes in.
Yep.
So usually it's easier to be fast paced when I already know what's going on. They're now asking better questions, or, hey, you said I feel this, and this is exactly what I feel now. Cool. Let's move on to the next step. What's the next goal? I'll see you in a week. Let's do these set exercises. I use those exercises not only as corrective exercises, but also as tests. So if this bothers you now, scale it down a little bit to the point you can do it, but also try to do it a little bit more. Try to do the part that hurts. Let's just wait 3 days. Once you can do that, now I have a day in and day out orthopedic test of sorts that I can now use in my decision making, because you're already doing the work for me. I'm just listening and trying to think outside the box, trying to be, a little bit more creative. Whereas the scope of practice for most manual therapies do not give you the license to be creative, legally speaking, right? I can't go up and tell someone that gout is from their neck, right? So it doesn't give you a chance to be creative. But, if I can tell you, hey, let's get you moving better, that's going to help with your weight loss and your diabetes. Well, that sounds wild at first, but in reality, your body knows what it's going to do. It knows what it craves. So if we can get the GLUT4 receptors to actually bring in some of that glucose in the body by using the quad muscle, then you're going to crave different substances a little bit more. You're going to actually work out and actually decrease some of the insulin sensitivity. So on one side it sounds weird, on the other side it's like, oh, well, this is proven all throughout science. Cool. We just have to define it.
Yeah, and like one thing I'm huge on, right, is not only educating to a patient, but finding ways to communicate and educate simultaneously so that they're taking things home. Because it's so easy to talk past the patient or over their head or talk around them, being able to dumb things down. And again, you're not trying to insult their intelligence, but in reality, you're trying to bring information to them that they're going to be able to hold on to a little bit. And they're going to be able to apply to their situation. Because at the end of the day, you're trying to change their state, right? You're trying to help them get out of pain. You're trying to help them get past an inflamed season, whatever it may look like. We know pain is extremely complicated. So there could be emotional factors and physiological factors and neuroendocrine factors. And so when it comes time to communicating or educating to your patient, I just find so many doctors miss that crucial spot. They've got 5 minutes or 10 minutes, or they've got their orthos to get through, and they've got their checkboard and their ticks to hit, and they miss some of the most important things that we can do as doctors. And that's just can talk to your patient, communicate to the person, if you can just talk to them about the 4 pillars of health, if you can just touch on, even if it's just briefly. Recently did a collaboration with a neurosurgeon, Dr. David Johnson, and we talked about the 4 pillars of health. His opinion that up to 90% of the disease burden can be prevented or reduced through better communication and implementation of functional movement, optimizing sleep, nutrition, and reducing stress. So he calls those the 4 pillars of health. So yeah, what you're saying about education, I'm huge on that. I feel like as clinicians, everyone can do a better job at how they communicate. I think communication in itself is a skill. People go to school to learn how to communicate. People do 3-year degrees on communication. My sister did a 3-year degree in communications, and people go to school to learn how to communicate. And then you go to a PT school or chiro school, and in your 3rd or 4th year, you're thrown into dealing with patients, and you're sitting in your cubicle, doing your history, and you can hear your friend next door he's struggling. His communication's just boom, and you can hear it all happening. And that's not to say that I was amazing, but we all have to learn. It's one of those aspects, those sub aspects of when it comes to being a clinician that doctors could do better. I think doctors could, all clinicians absolutely can communicate better. And when you're communicating about something that's so important as the pillars of health, or even how you're going to treat that person, it's important that you know how to do that. So that's one thing I think we leave on the table. The question is, based on what we've been talking about, Dr. Andre talking about with sports athletes having a team, you talked about positives and negatives of having a team or working with others. For you, Dr. Stephen, and touching on that creativity, right, which you mentioned, sometimes you're not allowed to be creative or do this or that. How do you do that in your practice when you may not necessarily have a team and you have people coming to you and you're having to kind of pull from all these areas, right? Like you're going to have to pull from a PT or AT or a strength coach and a chiro, and you're kind of pulling these treatments together to try and help this person just get better. What's your thoughts process on that?
I pull from the giant toolbox piece by piece. I don't overwhelm them with too many things. I try to do what I can with as little as possible, adding in small things, seeing if it works, if it doesn't work. And I keep an open line of communication with my patients. Most of them have my phone number because I'll text them, make sure everything's going well. We'll modify things as needed in between visits. And that's kind of how I approach that.
Do you have patients that are seeing ATs, PTs, strength coaches, performance coaches as well as you?
Yeah, sometimes. And sometimes I'm the sole provider.
How do you work with others?
It depends. Depends on who they see first. If I'm the new guy on the totem pole versus the original person, I'm going to have a different voice.
Okay, so Dr. Andre, in your opinion, what benefits can a person get from spinal manipulation? If we were just to look at that, if we were just to go right down specificity, like in not only what you've read and learned, obviously, through your education, but what you've kind of also seen. That's probably what I'm also looking forward to hearing. And this can be for the average person, or this can be for the athlete.
I'll say 3 actually. So the first one is, I guess we can chalk up to pain neuromodulation, right? One way to kind of think about it is ice. What does ice do, right? We kind of know it doesn't do much for healing. Yeah. We've kind of proven that, right? Mm-hmm. But people still use it and it still decreases pain. What's going on? The way I explain it to patients is, so ice is a hazard to the body, right? It kills tissues. It causes tissue death, frostbite. So your brain senses it as cold. Cold is harmful to the tissues. Your brain wants you to stop being an idiot and save your tissues, take it off. Tells you it's cold. We ignore it long enough, it goes from cold to that annoying, burning, stinging pain, which is usually a strong enough irritant that we take it off. If you keep ignoring it, your brain's kind of like, all right, this guy's an idiot. We're going to lose an arm or leg, whatever you have it on. Let's just numb the area. So it pretty much unplugs the TV of the reception going to that part of the body. So in that case, I'm going to use ice in certain cases where it may not be whole peace and love or price principle, whichever one you fall under. Yep. It may not be with the evidence, but the way that I'm using it, I'm trying to modulate pain so I get as much normal motion to that tissue as possible. The best way to heal a tissue is by loading it for most of them. So we have to be able to load it without pain so we're not compromising other tissues in the same process. So if we can do that, manipulate it, get as much freedom, range of motion as possible to help push out some of that inflammation, then by all means, I'm going to do that. I'm going to do that with hopefully some type of mobilization. A PT might do that through a milking type of massage. If it's like, a swollen ankle, maybe through smaller grade mobilizations, or maybe focusing on the muscle alone and letting that take care of the joint because muscles move joints. I don't care. It's the same side of the street. The second one is probably proprioception. So gapping the actual joint capsule itself with all those sensory organs within the capsule that lets our body know where it is in space. If we can help increase that signal to the brain, then it's better able to compensate without tuning it out. We can kind of chalk this into like phantom limb syndrome, right? Your brain knows there's a nerve that used to go there and it's still trying to search and search and search. So you're amputated at the knee, and you still feel your toes, right? That's kind of a freaky part of your brain that's not communicating. Well, if we can stimulate it and get it to work with us in the way we want it to, then we can kind of do some cool things as far as getting patients back a little bit easier, increasing maybe some force output so that they can actually do the rehab better. They can get back to skill specific stuff.
Yeah.
And then the third one is the most tricky one. It's helping the brain compensate. So one thing that I think we don't give enough credit for is neurology is pretty amazing, but it's also pretty stupid, right? Our brains are constantly computing. So at no point in time in our entire lives is our body 100% okay. Our brain is really good at compensating, so it lets us think we're okay. So whatever I can do to help the brain compensate better, then whether I'm actually helping that person like on a microscopic level, freeing up nerve interference, whatever you want to chalk it up to, innate intelligence, then my job is done. My intent and what I wanted to get out of it's done. How I explain that to patients is it's a brain game. I'm from Louisiana. I can tell them it's voodoo. I don't care. It's whatever helps them understand that it's not me, it's their body doing it. I'm just kind of being an accountability buddy and helping them out along that way. Yeah. That could be a PT, it could be a massage therapist, it could be acupuncture. Yeah. I don't know. It could be placebo with Smarties. I don't care. As long as we're getting the brain to compensate, then my goal is achieved. The patient has a better life, better quality of life, I should say. So it's a win-win across the board.
Yeah, recently I put a post up and I was talking about, it was actually from our last podcast, and I was talking about how spinal manipulation is the closest thing to exercise that's not exercise. I even prefaced it and brought some context to it, saying that a lot of people would give me hate for saying that, but I explained my points. For me, loading, movement, functional movement's always going to be the most important thing. But there's something, and I've said this before, that quite profound that can happen with spinal manipulation. And I think the sad thing is that chiropractic is finding it really hard to move past this philosophical model, this bone out of place, this pressure on nerve, this thing we learned in school, when there's this whole new future for chiropractic if they wanted to embrace it. And a lot of that's being spearheaded here in Auckland, New Zealand by Dr. Heidi Havoc, she's the lead researcher of the research center that's on campus at NZCC. There are some fantastic things that spinal manipulation actually does. And we're really just scratching the surface on some of these mechanisms and understanding some of these mechanisms. Using it for rehab and even sports performance is extremely viable and useful way of using it. And it's just funny because a lot of non-chiropractors will get really pissed off when you say things like that, and then you'll get accused of being like an old school tour or someone that's just based in philosophy. But the reality is that we have the research now showing that it does modulate pain. It can increase strength output or force output on the short term, which is measured through H reflex and V wave. We know the proprioception thing's amazing. We've got research now looking at feed forward activation, research looking at elbow position sense, increased proprioception. Me and Dr. Woodbury did a case study where we saw a significant amount of increase in proprioception and spatial awareness following a seated MPI CT junction adjustment. We know that it increases ROM. Like, this stuff it's in the literature, and anyone that needs it, send me a DM. I get DMs all the time, people asking me for literature. I think it's just because people can't be self-searching it themselves. But from my PhD, I've got like hundreds of references that I can send to people that I've gone through, looked at every little study, and there's a lot you can get from spinal manipulation. So you don't want to take it off the table, and that's the most important thing. The problem is when we get into the weeds with certain profession groups thinking that, you can move certain bones or one bone at a time, or specificity, or, only chiropractors can do it. It doesn't have to be this big like woohoo thing when it comes to adjusting. I think you can get a lot out of it, even if you're doing it in a non-specific manner, to be quite honest. I don't think you need to be like, oh, T4, I'm only going to move T4 because that's pressing on the nerve, and that nerve's going to go and it's going to annoy the corresponding organ. Oh, your thyroid's not working very well. Oh, No, we better go ahead and carve a bridge that up. You know what I mean? I just like I don't really like buy that methodology around it. But as you said, the way you explained it was awesome. Definitely agree. Stephen, what do you see when you treat patients when it comes to adjustments? Do you see initial immediate reductions of pain? Do you see that pain modulation thing? Do you see that increase in ROM? Do you see the proprioceptive aspect? Like, what do you see in your experience?
Yeah, I see all sorts of those combined, some of those missing, some of those come and go with the adjustments. It's completely varied with each person, but at the very least, I always see an increase in ROM. Most of the time, there's a reduction in range of motion.
Yep.
Sometimes there's a better balanced coordination with it.
Me and Dr. Mike in our case study, we touched on the possible benefits of implementing adjustments to the older population because some of the studies are directly on older people and being able to restore gait post-stroke, being able to restore walking patterns or gait function. What are the possible benefits of applying that to the right candidate? And the person's like, you want to adjust old people's necks? It's like, did I say that? Like, did I stutter? Like, no, I didn't say that, man. Like, come on. Like, we need some context. Like, it depends. So people are so easy to jump on. As a physio, so easy to jump on and just like attack what we're saying. But if all professions can jump together and really think, hey, like I say with the physios 10 years ago, they're like, oh, cross friction massage, it's gonna work. It's like, come on, we got the studies now. We know that it's freaking a flip of the coin. Might help, might not. Increase blood flow. We know we're not changing the architecture of the tissue. We have the research now. It's pretty straight up. The thing with spinal manipulation is, although parts of the philosophy need to die out, spinal manipulation itself does not. I'm more than happy to fight for that because I think it 100% has the power to really help people. Talking about that, Dr. Andre, question here. What separates your approach as a chiropractor to the more traditional chiropractic model? And then off the back of that, feel free to tell me what pisses you off.
What pisses me off the most is the Messiah complex.
Oh, yes.
That, at least that's what I call like a lot of the talk the tick, tour, miracles. We as a profession have historically gave ourselves too much credit, right? Yeah. At the same time, we will shun any MD or DO surgeon that, says that they fixed a fracture, right? We're really quick to put innate intelligence saying, oh, the body was going to heal itself anyway. The surgeon didn't need to do that, right? They didn't fix anything. Well, you're right. It didn't. The bones remodeled itself, and the spacers or rods or pins are just there to kind of guide it. You're doing the same thing, right? So it's like, it's the same side of the coin, right? It's still dirty. It still lacks a lot of context. Yep. But the more I can let patients know that I'm not doing anything special besides allowing them to be the best version of themselves, then by all means, that's where I go with that. But the way that I do things is I care about you moving. So if you're moving better, my job is done. Wherever I may be able to plug my other experiences into or my other nerdy Snapple facts into, then cool. If it helps you, awesome. If it doesn't, I still have a Snapple fact stuck in my head for the next 5 years I'm probably never going to get rid of. But at the same time, I've learned a lot. I had a patient earlier today, post-pregnancy, developed hypothyroidism. Well, the docs want to, your TSH is low, so we need to put you on Synthroid. Doesn't respond well. All of a sudden, she starts feeling better, comes off the meds, and she's fine. So she'll now have that information being, oh, well, you don't need Synthroid. You don't need this thyroid medication. It's like, no, because you're wrongfully diagnosed with hypothyroidism. Mm-hmm. You probably had a transient version of subacute thyroiditis from postpartum, and you went through that stage of hyperthyroidism. You had all this energy. Next thing you know, you hit a crash. You finally get tested because you feel bad. Hypothyroidism at first probably feels pretty good if you just been carrying a parasite for 9 months, right? So there's also a lot of context as well where I think as clinicians, we don't see people enough. And that early, going back to like one of the first questions you asked me, that's why I think wellness care is actually pretty important. Or continuation of care, I should say, is pretty important because people change day in, day out. We have to be able to insert ourselves in an ethical way at the right time. If you only see someone once a year for a physical, that's completely pointless. You're taking a small snapshot of 365 days of blood work or blood pressure of whatever pathological process is going on. So if you need PTs or physios or athletic trainers, personal trainers can go through in there, DCs, to help that continuation of care, to know when to push you into the medical system. I'm fine seeing a patient once, twice a month for that reason, because I know what I'm doing with them is at least evidence informed, but as well as I'm always trying to push them to tell them to keep going further. Don't settle. Just keep going, keep pushing yourself. I want you to be sore every time you come in here. Because if you're sore, most likely you're doing enough to stress your body to heal, whatever that may be. Like you're talking about the geriatric population manipulation with proprioception. I can't tell you how many times I've had patients with Parkinson's have less intention tremors. Am I doing anything crazy? No. But at the same time, if we are tricking the brain to getting on the same page, then yeah, there's a little bit of modulation we can have there. Now, if you want to say they're less of a fall risk because they're not, their body's responding quicker, how's that an issue? If you're doing it ethically, if you're doing it in a way that is safe for that patient, talking about osteopenia and anything like that, what's the issue? I've seen plenty of cancer patients who never once have had any type of pathological fracture. So you have a patient with bone cancer that's brittle, but yet they still get benefits from manipulation. Why is that? And it's because I'm listening to the patient. I know when not to and when to, 1,000 different tools to be able to do what I have to do to get that patient better.
Yeah. There's a paper done here in Auckland, New Zealand, a really good study where they looked at a cohort of older people and how an adjustment impacted them. And they saw a reduction in step reaction time. So their proprioceptive ability to move increased and their ability to reduce that reaction time, which meant that they were less likely to stumble pretty much. So they were literally, rather than being like, oh, if I adjust them and they feel better and they move better, that might help them walk better and that might reduce falls. Well, they actually looked at it and they're like, we're actually going to look at it. We're going to get a bunch of old people. We're going to send it. And then we're going to test them. And it had some really good results. More research is needed, as always, more context and more work to be done in the scientific community for that stuff. But it's exciting to see. Yeah, really interesting take on wellness care, for sure. Or like you said, maybe you saying wellness care probably has a negative connotation. The way you explained it made a lot more sense. Making sure that people are functioning and moving and biomechanically are sound throughout the year, not just coming in for a snapshot, makes complete sense. I think there's just a bad taste in so many people's mouths because you've got the classic philosophical based model where they're like, I need to see you 4 times for the first 2 weeks and 3 times for the next 2 months, and then I need to see you twice every week for the rest of the 6 months, and then we're going to get to wellness. And I'm sure you've seen all those like those graphs, and they're like, if this is like feeling good, after your first adjustment, that this is pain, we're going to get you here. Like, don't give up then. Like, keep coming 5 times a week because, this is really where we need to get you. But you're not going to feel any different. This is not going to feel any different. It's like, come on, man. Like, that is what is that negative connotation comes from that. And we laugh about it, but I'm sure you were taught it and I was taught it. I was sat down, I was given the sheet, I was given literally given a graph that looks just like that. And I was told, hey, report of findings. You can just sit your patient down and you need to tell them that this is how we do it. And this is how many times they need to come. And this is why they need to be coming for the rest of their life. And they can never not come because of this. And then you go and you communicate to your patient. And I found that was extremely unethical. I think people are extremely resilient, and I like to be positive and educate, but also encourage them to move more into hopefully lead happier lives because of the treatment that we're doing. A couple of more interesting questions I'd like to touch on. In your opinion, what makes exercise, movement, and rehab so important? Having that ability to understand movement, biomechanics, physiology, having that piece of the pie, what makes that so important? Because we know there's chiros out there that don't know that, right? I've discussed this with Stephen before. He's got a background in exercise science. Like you've got a master's in rehabilitation. You've got this. You've got a background with it. But there's chiros out there that do a crappy undergrad. They do 4 years of 3.5, 4 years of chiro school, and they're out there promising people that they can get them better from anything. One person comes to mind that me and Stephen talk about regularly that was in your year and class, promising on social media that he can help everybody with, but he has no shit all when it comes to exercise, movement, functional movement, or rehab. Anyway, rant over. What's your thoughts on that?
I kind of still out of Jordan Shallow's book. Are you familiar with him?
I know Jordan well.
So good, because he is one of my favorite people on the planet. So like the functional basis of how we evolved, right? The only reason we're even here today and can do the things that we can do that is pretty amazing is because we were movement creatures, right? The more movement and the more need for movement we had, we developed more and more. We started having this higher order thinking to be able to do these movements in a cleaner, more efficient way so that we're not using as many calories to go hunt, whatever, go down the evolutionary trail. But our brain is processing that way. So our brain's always constantly taking in stimulus. So if we need to challenge that, because if it's sedentary, people die, right?
Yeah.
Now we can go down that rabbit hole of saying, dying in terms of what, but whether it's your individuality, your freedom, your mental fortitude, I should say, you have to move to challenge that. Yeah, you can do all these brain games, right? You can read the dictionary, do whatever you want, play chess, but there's nothing more intricate in our body than being able to move in a very precise way and doing it so that every little bit of force and every joint is lined up adequately, and being able to use just the correct amount of muscle fiber. Like if you go into the weeds of how a muscle actually works, it's an amazing thing, and it's a million different possibilities that could go wrong. There's some people out there that don't understand, like they're so amazed by AI, right? They don't realize our brain's constantly doing that anyway. Yeah. Like it's an amazing organism. So more exercise, movement, anything like that, it's more of just a tool to train the brain. It's just kind of how I think about it. Most sport that you do is actually not a muscle joint thing. It's maybe 10, 15% muscle joint. The rest of it's neurologically speaking, right? So like strength, you don't do anything for 3 weeks, you're gonna lose a lot of strength. That first week you're back lifting, you're gonna get your strength back up pretty good. Like maybe 80% of what it was, 90% of what it was, depending how much you lost. That's a neurological adaptation of it though, right? Yeah. How much muscle fiber you're able to actually recruit. Yeah, it's going to be a lot easier that way because it's the neurological process. Whereas what holds you back is that muscle fiber being detrained, not having enough, whatever, sarcomeres, or I guess we call it ATP being available, right? So there's still the physiological, but majority of it's still neurological. Yeah. Sprinting, one of the most evolutionary functional things you can do. Look at the body types, right? They're tall, they're short, they're fat, they're skinny, they're muscle bound, they're lean. Nothing makes sense. It's because it's all neurological. How fast can you turn a muscle on and turn it off in an efficient pattern, right? So if we can take the best of the best that do that with their brains on a daily basis and whittle things down to a normal person, your general population, they can get amazing results with very little effort, because if you can treat that 1%, you can treat the other 99 very easily. It's always easier to regress on a patient than to progress a patient, mainly because of all the variables involved in lifestyle habits. You're not babysitting them all day, right? They might tell you, I didn't do anything. And then they've got to tell you a dog jumped on them and they got into 3 car wrecks, right? So it's pretty wild that way. But I mean, it's also hard because people want to pathologize exercise. They'll say a certain movement is bad. Yep. So then now they're listening to knees over toes guy go on Joe Rogan and talk about how he had to scour the ends of the earth to find this information, when all he had to do was turn on the Olympics, watch 400 people doing the exact same thing he's talking about, and have been doing it since the Roman times. Yep. You're not doing anything special. You're just blind to the fact, and you found it later in life and you're trademarking it. That's not functional movement. That's being ignorant, right? Yep. So there's those aspects, and I think that's what makes exercise and movement a lot more taboo. I still am in the camp that a Turkish get up isn't functional, and I will die on that because I've never once have seen that or done that in my life. So if I can do the decathlon, which is, run, jump, throw at a pretty decent level, I've never once had to do a Turkish get up. World record holders have never once done the Turkish get up. So that exercise we can do without, but all the rest of them, we can probably find a use for them.
Yeah, I mean, I know people say it's almost the cool thing to say right now is, you're either on one side of the camp where you're fear mongering based on certain exercises, or you're on the other side where you're like, hey, there's no bad exercise. It's just the context of the exercise, which is probably not necessarily quite true either. But the whole Turkish get up thing, I don't get it either. I've never programmed it. I've never done it. I've never seen. Yeah, I understand aspects of it, like possibly loading into external rotation and stacking the shoulder joint and rotation through the body. I understand aspects of it, but why not pull those apart and load those in a more effective way individually? If you require rotational strength, if you require shoulder, this, that, I've never understood why you'd put it all into one system, and every part of that movement is now sacrificing for the other part of the movement. So you're getting mediocrity throughout the whole movement, and it's just immediate. I feel the same way. People will probably jump on us for saying that, but You know what I mean? And yes, what you're talking about skill, technique, technical prowess, ability. When it comes to a lot of strength training, I like to keep things simple. I'm not moving into a lot of different exercises or dealing with a lot of people that do a lot of different movements. But even when it comes just to some really basic skills like squat, bench, and deadlift, or weightlifting, which is a lot more technical, I understand. If you look at the stimulus recovery adaptation curve, it's always the skill or the technique that goes first, as pretty much what you were alluding to, and then the strength will go as well. But like you were saying, it's the brain's capacity, it's that neurological ability to coordinate function, being able to coordinate how you're moving in a sport. So important, and something that I think a lot of people overlook and misunderstand and misinterpret, if I was to be honest. Awesome answer about the rehab, the strength, and the exercise. Super, I'm on the same page. I love Dr. Jordan Shallow. He's an absolute legend. I love the way he's got a really great way of thinking about things and analytical mind. He's able to break things down, and it's really, really awesome. I am interested. This will be a bit of a fun question. And Stephen, you can go after if you want, because I'm keen to hear your answer as well. What's the wackiest thing you were taught in chiro school?
Oh, God. So let me preface this with, not all chiro schools are taught this, right? I went to the most philosophical chiro school. Because it is such a institution in the country, we have some great professors that are very evidence-based and just kind of hide in the closet. You have to kind of find them. So they started opening my mind up to kind of thinking about things a little bit more critically. So one of which was one of our technique courses. I won't say names because I don't want a defamation lawsuit. He never said this outright. He always kind of hinted at it, but in his research article that he published, a case study about how an internal coccyx adjustment helps with headaches.
I was just talking about this with someone. Okay, carry on.
So most people in our world would know Logan technique, the brown thumb technique that's illegal. Yeah. But this was specifically talking about CSF fluid movement through the sphenoid and like the sacrum pump. But by, I guess, stimulating the internal coccyx, you can modulate that for migraines and headaches. And he never once talked about it. He just kind of threw that research nugget on there. And that's when I really started realizing that research can be whatever you make it, right? And that's where I think right after that we had COVID. So I was like, oh, this was a wake-up call.
Wow.
And I was like, I wonder how many people are getting internal coccyx adjustments for COVID. We were kind of shown how to do it through like an external skin pull, just because of the fascial connection from like the skin and the coccyx being so close to each other. Yeah. But it's almost like transient, very acute like impacts that you would do it with.
Like the sacral tuberous ligament one. Did you get taught like you shoot across the we got it. Yeah. I mean, it's all a bunch of, but it's funny because Andrew said that he got taught the same thing in his post-grad physiotherapy course. Mm-hmm. So that's interesting. And Stephen, come on, give us a good one.
So I had this professor, won't name names, but they had a student adjusting their CT junction pretty regularly. The exact same area was apparently always flared up for like several weeks. And then the quarter ended and they had a heart attack right after. And so they missed out on a whole quarter of teaching. And they came back and they told us that the reason they were getting their CT adjusted was because of the nerve interference from that vertebra that was irritating their heart. That was their biggest red flag. That they should have been anticipating a heart attack any minute. But they neglected that, and they wanted to make sure we never do that with a patient in the future. Never neglect the fact that the stuck CT junction is indicative of an impending heart attack if it's always the exact same sign.
Yeah. I'm going to add another layer.
Go for it.
Another layer to that is we're talking about the same professor.
Yes, we are. we are.
I like that. Okay, I think okay. Well, the worst thing I was probably not taught, but the worst thing I heard was one of our. We won't say names. Let's just say someone in authority at the school told us a story about how one of their patients had a heart attack, was having a heart attack. So they called the ambulance, and then he's like, "Yeah." Then I adjusted him. So I was like, what the hell is that? You know, like, yeah, he's having a heart attack. Really? Yeah.
It happened recently with the Fix Worlds Games in Birmingham, Alabama. You had a Georgia Chiro, I think it's a Georgia Chiro, a sports Chiro, who was a volunteer. So at this, the medical team side of things is you're supposed to clear them for the medical management. If there's anything active going on or acute going on, MDs are first call. Once they clear them, then you can treat them, right? But you're not treating them chiropractically. Really, you're just kind of making sure they're good for their event, whatever that event may be, whether it's bowling or taekwondo, whatever it is. Well, someone is having a heat stroke, and it's rumored that a chiro may or may not have adjusted them and brought them out of the heat stroke, which I don't know what about philosophy told them that, because I didn't learn that in school. And yeah, that's a talk of the town now in the Fix world, which is, I guess, the international version of our diplomat of sports. So that's a chopping block topic right now.
And it happened on an airplane ride, right? I remember a couple.
There's always an airplane.
A couple of Instagrammers covered a story where a chiropractic guy claimed, I think it might have even been on the FTCA Facebook. But anyway, some guy was having a heart attack and then he adjusted his neck and he came out of it. And they got slammed.
It comes around like once a year.
That's hilarious. Anyway, we've clocked well over an hour here, so we'll start to wrap up. Is there anything else you want to ask, Stephen?
I'm good.
I had a great time chatting to you, bro, and I'm sure I speak for me and Stephen when I say we'd love to have you back on, especially having you on with like another student chiropractor that has a slightly different take, where we could, like, all four of us could actually kind of talk, like, duke out some really awesome conversations around some great topics. Because you're a super smart guy, you have a really good insight into your experience as an athlete. You bring a lot to the table, so it'd be awesome to see. Ask if we could talk to, like, have a really good conversation with someone else that could bring a different perspective. Because I think we probably have really similar perspectives, like all three of us. But I really appreciate you coming on. Thank you so much, taking time out of your, is it Sunday afternoon for you guys? It's probably 6:30 now-ish. So, yeah, really appreciate that, because I know you guys are both really busy. I know you're busy, Stephen. So thanks for co-hosting. Hey, thanks for doing your own podcast, Stephen. I appreciate it. But yeah, thank you for coming. Any final words?
No, thanks for having me. I know we didn't really dive too far into chiropractic, and it's more, the overseeing scope of things. But I think that's where the conversation kind of has to start. I get a lot of patients from ERs, surprisingly, and it's kind of counterintuitive, right? Because we supposedly cause so many strokes. But I think it goes to show that if you can talk to people and have someone understand, is you choose a doctor based off what you connect with them with. It's not about what they're doing per se. Like, yeah, it's a little bit, and you're getting treated by another person. You have to like the person. You have to be able to understand that person understands you and build that faith. So I think that's where a lot of the PTs, the chiros, the MDs can all come together, is on that. Now, they can argue about all the other stuff in the weeds. I don't care. I don't waste my time with that anymore. I don't have the energy. I have too many kids. But it's something that I think we need to do more, because there's always three sides to every story, right? Yeah. Your side, my side, the truth. The truth is always kind of in the middle. Stu cheats and says it depends. I think sometimes we can just call it out and say sometimes it depends, but hey, it is what it is.
I like it.
Thanks for having me, though, guys.
We appreciate it, man.
Introducing your host,